So, welcome back, everybody, to the GP Notebook podcast. It gives me great pleasure to introduce back to you Dr. Rashbal Ghattaora on this second of our 2 episodes on altitude medicine and getting involved. Welcome back, Rashbal.
Thank you very much, James, for inviting me back.
Well, really nice to have you. So, last time we talked a lot about that consultation that you might have as a clinician where a patient might come and say, hey, I'm going on a trip to Kilimanjaro, I'm going to altitude, what shall I do? And we talked all about the questions to ask, thinking about planning the trip out, a bit about medications and the like. But today we're going to talk about some of your experiences and some of the experience that you've had in leading the groups in altitude and what to do if you happen to be the medic.
That's correct. Yeah, James. So just to sort of recap, we had last time we discussed what would happen if a patient would knock on your door and say, "I'm off to Kilimanjaro, doctor. What do I need?" Yes, and just sort of have a foundation. But now you're the doctor that's accompanying them. That's the scenario that we're gonna play around with today.
Yeah, brilliant. And what's your background in this? What's your experiences?
Good question, James. So it's like with most of these things. Often you're a participant, really. Actually, I remember going to some of these trips, like the trip to Tibet, as a participant, and then shadowing or watching and discussing with the doctor that was managing us at the time to say how did they get into it, and they share useful tips, and I basically followed suit. Really, actually, I realised that when I came back home that I needed a bit of training. So what I did was I went on a altitude medicine course. Yes, a lot of these are often run by the expedition medicine course organizers. That was really useful to give you a bit of a foundation in terms of physiology and understanding what altitude is and what the impact of altitude medicine is. I thought then it might be useful to do a bit of pre-hospital trauma update. So I did that as well. So I just thought that gave me the foundation. And then on my first trip, what I decided to do was to shadow somebody. Yeah, so I was almost like their assistant. Yeah, just to sort of get a feel of what sort of issues would arise, what sort of kit that I need to be familiar with. So that's basically how I started, James.
Oh, brilliant. I mean, I think learning from examples and learning from those experiences often is a really good way to be inspired. So doing things that you love and following in the footsteps of people that you admire, I think is a really great way of getting started in this sort of stuff. So preparation really important, learning some stuff about wilderness medicine, what to do when there isn't a hospital around, when you've only got limited kit. You did mention some kit which we're going to touch on at certain points today. Is there anything else to think about apart from these courses when you're thinking, right, okay, so do you know what, I want to be that expedition doctor?
That's good, actually. You're right. The enthusiasm is one thing, but fitness is really important. You've got to be fit as well, because there's nothing worse. Can you imagine falling ill on the first or the second day of the trip, thinking, "Oh my gosh, the doctor's ill"? So, in other words, you have to lead by example. So, do a bit of preparation, start training. If you're going to altitude medicine, I often say do a bit of cardiovascular. I often find swimming is really useful. Actually, to say that you feel quite fit and confident. And then we talked about you've done your training, your indemnity cover as well.
Yeah, I can imagine that's a tricky one. You want to make sure that you're covered for the work you're doing out there, but also for being out there.
Yeah, so it's really important to speak to your respective defence organisation to say, would you cover me? Yes, and majority of the time, if you're doing it on a charitable basis, then they would say yes. But obviously, the landscape has changed with regards to defence organisations at the moment. So please check. That's important.
Yeah, okay, that's important. There's I suppose cover for you there, and there's cover for the trip itself, isn't there?
Yes, it's good for the trip as well. So the organisers would provide that cover in terms of if you fell ill. But I think it's really important, just like any other participant on the trip, to make sure that you also have your appropriate health insurance. Okay, and we talked about some of these health insurance companies where they cover a certain altitude. So you have to be really careful that do they cover the altitude that you're going to, because some of them charge a little bit extra if you're going above 5,000 meters.
Yeah, I mean, there's my experience when I went to Annapurna. There was, I think it was actually 4,500. But as we were going to 5,500, there was a fairly big premium above that because, of course, the risks increase the higher you go.
Exactly. And if you're looking at evacuation by helicopter, you can imagine the escalating costs that might be associated with that. So
Yeah, sure. I mean, a lot of this really resonates with me because of during my Annapurna trip, I got on quite unwell, which we're going to unpick a little bit in a second, and furthermore needed a helicopter evacuation. Fortunately, not for my health, but because the weather went a bit crazy. So I think, a lot of people have told me this while high altitude hiking or skiing, you've got to respect the mountain. You've got to respect the environment that you're in, which is harsh and changeable, um, and to take appropriate precautions. So I suppose talking about appropriate precautions, um, if I was going on a trip, what would you do? How would you approach that? If I was thinking, right, I'm going to be the doctor on this trip. Where do we start with that?
It's a really good question, James. So I think it's really important to meet with the organisers of the trip, yes?
Hmm.
Just to have a clear understanding of the itinerary,
Hmm.
in particular the altitude, the various altitudes at the stages that you'll be travelling, and also clarifying with them whether there's any acclimatization days or rest days.
Mm.
Because that's really important, isn't it? Because if you know that a trip has those, then the chances of the group falling ill become less, especially with
Mm.
altitude
Mm.
sickness. So, but if it's a tight itinerary and there's some rapid rises and ascent included in that itinerary, then you have to sort of alarm
Mm.
bells start to ring that actually I need to be a little bit careful in terms of making sure that, do I need to advise a group before they start the trip about pharmacological treatment? Yes,
Mm.
pharmacological prevention treatment, shall I say.
And just recapping on what that pharmacological prevention
So
was.
we talked about Dimox or
Yes,
acetazolamide being
exactly.
the thing that's the, the most evidence-based at the moment,
Mm.
really, actually, and to start that a day before you
Mm.
arrive, okay? And we talked, I think last time we
Mhm.
mentioned some of the classic side effects and stuff of
Flat beer.
flat beer, diuresis, yes,
Yeah,
and sometimes a bit of noise. It can make a bit of an
yeah.
upset stomach as well. And you have to be a bit careful about sulfur allergy as well.
Mm.
Yeah, so so I often inquire if there is, what sort of allergy is it? If it's a rash, you can probably get away with it, but if it's more sort of like a proper anaphylaxis, then you really have to think about an alternative.
Yeah, absolutely. And the diuresis is very real. Whilst I was taking it while I was unwell in Annapurna, I was up 3, 4 times a night, which when you are feeling terrible is hard work.
Hard work, isn't
It's
it, and
really
stuff.
especially squat toilets as well.
Very challenging.
Yeah, very challenging. Okay, so right, we've met the organisers, we've talked about the itinerary, and hopefully, I mean, anything about acclimatization for the doctor themselves, because of course we touched on it just a second ago. Doctor falls unwell, the rest of the group is going to really struggle.
Yeah, and so from that perspective, it's really important that the doctor also takes appropriate measures. And
Mm.
if there aren't sufficient acclimatization days included in the itinerary, I think it's really important that you start pharmacological prevention treatment as well. In other words, Dimox as well. Yes.
Mm.
So it's important to take your own medication
Yeah.
as well as advising others to do that. And it's also important when you talk to the organisers to say to them, look, if one of the participants was to fall ill on stage 2, stage 3, stage 4, what's the process for actually getting them down? Because
Mm.
that's really important, because what you want is a clear plan, just in case somebody falls ill, what's the evacuation
Mm.
procedures?
Yeah, that's really helpful, especially having an experienced guide. Um, and throughout my own experience, and I suppose I'll just for listeners, just to recap exactly what happened, I went on an Annapurna circuit trip. Started to feel unwell about day 4, not at particularly high altitude, and then sort of plateaued in my unwellness, but trying to figure out what to do. And speaking, there was no doctor on that particular tour, apart from myself, although I wasn't very well very well armed for this, and much more so after speaking to Rashbal, of course. Um, Actually figuring out what the options were, and the guide was talking about, well, you can take a donkey or a horse down to the next place where you can get a jeep, or you can go to here where you can get a helicopter. We can go on to the next place, which is not any higher than we are at the moment, but your options there are becoming limited, and trying to figure out where that threshold is reached is really difficult.
It's very difficult, really,
Yeah,
actually. And it sounds like your guide was very experienced there,
very
really, actually.
experienced.
And
Yeah.
it sounds like he did the sensible thing, which was to say, you're not well at this stage. It seems pointless taking you further because you're just going to get even
Mm.
more unwell. So it sounds like the guide's thought process was, let's
Yeah.
bring him down safely.
Yeah. And of course, it's difficult from the point of view. So you've got the guide or the doctor saying one thing, and you've of course got the participant. And again, I'm a fairly well informed sort of person that understands some of the risks of HAPE and HACE, and under this. But I wanted to continue, despite feeling like death warmed up at some points. Paid a lot of money to be there. I wanted to go. over the pass that we're heading for, the Trongla Pass. Um, but I did, I didn't want to turn back. And of course, I would have fought that a little bit. Although I must say, I didn't have too much strength.
And that's often the challenge. So, the participants will say, look, I paid for this trip. Yes, I've
Mm,
taken time off and
mm,
I think I can complete it. But sometimes they're so unwell, and suddenly you're thinking to yourself, are they in the right frame of mind to make the right decision for
mm,
them?
mm,
So James, sometimes at the start of a trip, what I often do is I often speak to all the participants and say to them, look, my role is to keep you safe and to make sure that you return home safely.
yeah,
Okay.
exactly. Yeah.
And then I say there may be situations where, you know, we have to bring you down. Okay. And I want you to understand that those are not easy decisions to
Mm,
make, but they're in your best interest. That's why I try and reinforce,
yeah.
just to sort of balance that, because that level of conflict will occur when
Yeah.
somebody's unwell, thinking,
Yeah.
my colleagues, my friends are going up, I'm sure I can make it. And you're thinking, actually,
Yeah.
you're in that state where it's much safer for you to go down.
Yeah. And I think that's got to come up quite a lot, and particularly Kilimanjaro is the example that jumps to mind, because you can do 5 days, 6, 7, 8 days. The number of people finishing it at 5 days, I think, is in the region of 50%, and 85, 90% at 8 days. But of course, you're looking at almost double the cost. And for people looking for that, especially students looking for that life affirming experience, they're going to want to keep costs low. And they think, well, I'm 23, I'm fit and well, but that doesn't make them immune to Hape and Ace, eh?
Doesn't actually. And what we don't want to do is for them to have a life-ending experience.
Yeah, well, quite right. Yeah, yeah, yes. Life affirming, important, life ending. You come back and try again another time. Yeah,
Kilimanjaro has one of the highest mortality
is that
rates.
right?
Yes, and I'm not sure when you been to Kilimanjaro?
No, I haven't, but I'm quite keen, but a little bit worried considering my experience at altitude in Annapurna.
One thing you do see is the porters rushing down with these trolleys. They have a single wheel, yes, and they're rushing the casualty down who wrapped up in the sleeping bag because they've obviously succumbed to altitude sickness. So I would say you have to be very cautious with
Mm,
those trips. There's a price to pay if it's quick.
mm,
Yes, you must. The best trip are those where there's sensible acclimatization
yeah.
days. And if there are sensible acclimatization days, you might not even need to take the prevention treatment.
Mm,
But if it's a rapid trip, then definitely seek
yeah.
medical advice, yes, and talk about, there in those trips, starting pharmacological prevention is essential. Otherwise,
Yeah.
you're going to fall ill.
Yeah. Okay. I mean, we'll move on to sort of the next part, which is, so if you are a doctor on a trip and if the situation is someone becomes ill, I'll give you an example close to my heart. So, a young GP that's really keen to finish the Annapurna circuit, and on day 3 at 3,500 meters, he's starting to feel pretty unwell. He managed to make it through the up to 4,000 and down to the sleeping area, getting some breathlessness, fatigue, and feeling pretty exhausted and just wants to go to bed and go to sleep. What classic? Well, I mean, it's exactly what happened to me.
Classic scenario there, James.
Yeah.
Okay, and so the first thing is we know that okay, anything above 2,500, the probability that this is altitude sickness is high. That's the
Mm,
first thing. So your radar's on now that this person's unwell. Yes, and the symptoms that you described, lassitude, yes, breathlessness,
mm,
they all fit in with some form of altitude sickness. So what our role is to establish, okay, is this in the spectrum of acute mountain sickness, or is this person now moving into that high altitude pulmonary edema?
mm,
Yes or not? Okay. And so it's really important to do some baseline observations. Yes, you've taken a detailed history, you've completed your Lake Louise questionnaire,
yeah.
yes, which is
Yeah,
one of
we
those
talked about that
questions.
last time.
Yeah, we talked about that last time.
Yeah.
It classifies things like headache, lassitude,
Mm.
dizziness, and all these things that are different things. So you've got already a bit of a measure of where they are on that scale. You're doing your oxygen sats. And tell me, James, what was your oxygen sats at that moment in time?
I get 79 at one point was the more 81, 82, and a heart rate of 135.
So, so this you can see that your system's under quite a lot
Mm,
of stress, really, actually. And so I wouldn't be frightened by the oxygen saturation at the moment, because obviously, if I was to do uh, at different levels, different altitudes, oxygen saturations of the group,
Mm.
you'd find that they'd average around, depending on the altitude, between 75 to 85. Yeah, so it's not that. But the ones that I worry about are the ones where you suddenly think, actually, they're an outlier. Yeah,
Mm.
everybody else is hovering within that range, but that other person is hovering around 65 and they
Mm.
look unwell. You're thinking their acclimatization reflex hasn't kicked in. So that's where alarm bells start to ring. So it's
Mm.
really important. Take a detailed history, do your obs, and say, okay, James, what we need to do is to try and work out, is this within the spectrum of altitude, or is there something else that could be explaining your symptoms?
Mm.
Yeah, so you've got to think, you know, could this be a chest infection? Yes. Could this be dehydration?
Mm.
Could this be low sugar or hypothermia? All those other things that should be on your radar as
Mm.
well.
I think that's really pertinent, particularly to my situation, because when I had that first day, and I was only breathless when I was climbing, okay, because we had loads of acclimatization days. We started off low and moved up by no more than 500 meters a day, but I was still slapped with it, and my colleagues that I was with were fine. One of the local remedies for altitude sickness is they gave me a garlic soup that is it's probably has about as much garlic as I eat in a year in a singular bowl, which was interesting. I don't know if it helped, but actually, the next day, sat still 79, 80. Breathlessness had gone, no headache, felt a little bit better. And I felt a bit better. And that was our climatization day at this 3,500 meters. So I'm going to move on to the next day, and you know, young GP moving on really wants to continue, but is starting to feel a bit rubbish again. But no headache, no breathlessness problem. And he's saying, but I don't think this is altitude sickness because I've got mild fever and all that kind of stuff. How would we approach this? How would we sort of temper their enthusiasm for?
By all means, we don't want to temper your
Yeah.
enthusiasm, but what we want to do is just try and work out what's safe for you. So,
Mm.
so the important thing is to obviously listen to your chest as
Mm.
well, okay? And if I notice some creps at both bases, then I know that you're moving into the realm of developing high altitude pulmonary edema,
Yeah,
okay?
HAPE.
Yes,
Yeah.
hey, so you've
Mm.
got low oxygen saturations, you've got this fatigue, you've got breathlessness or mild exertion or even at rest, and you've got creps. That's the diagnosis that's made there and then.
Mm.
So the question is, what do we do? The first thing is you definitely can't go up.
Mm.
Okay. The safest thing to do, if we can, is to take you down. But I'm sure that probably it's the logistics, really, isn't
Mm.
it?
Absolutely.
If this happens late in the evening, I'm not sure what time your situation was,
Yeah.
but you can see the dilemma that the leader of the group might have to say, actually, it might be difficult to bring James down.
Yeah, yeah. And in particular, again, respect the mountain. There was some absolutely crazy weather rather at the end of the trip, fortunately, that resulted in us having to get helicoptered out. But yeah, the logistics were talked about. So there was one aspect said, well, we can take you to this area and we can helicopter you for it. But it was a really difficult decision to make, especially because some symptoms had changed, and it was a negotiation, wasn't it, at that point? Um,
And the problem is, if you don't, as we go higher and higher up, the chances of evacuation become sometimes more
mm,
difficult. That's the
mm.
other thing to factor in, isn't it? If somebody's ill at that point, you at least need, if you think that they've recovered, you need at least 1 or 2 days at the same altitude to really
Yeah,
monitor them. And so logistically, that's quite difficult as well, isn't
yeah,
it? If you're the only doctor on the trip, for example, the group has its own itinerary.
yeah,
And to leave somebody behind with the doctor
yeah,
may not be logistically possible. And if I'm leaving a porter with you, then you think to yourself,
mm,
who's keeping an eye on you?
yeah,
So then there's that difficult decision. When you meet the group at the beginning to say, look, I want to do what's best for you. I
yeah,
want to make sure you get home. Having that conversation, say, oh my
mm,
gosh, James, I think the safest thing to do is to bring you
yeah.
down.
And in this situation, I mean, I wasn't the doctor on this trip, but had I been, this is absolutely just looping back to the very important start of this, which is make sure that you're safe and make sure that you're well supported in this. And just for people listening there, I'm not recommending necessarily what I actually did on this trip. It is not best practice, but at the same time, we're we sometimes do things that we later look back and go, actually, indeed, was that sensible? But I did make it, and I'm still here to talk to you all about it. So yes, being sensible is very important. So we talked about a little bit about HAPE there, and you mentioned some equipment earlier. So in some more sort of extreme situations, what can we do about HAPE apart from get down? Or for instance, it took us 3 days to get the helicopter at the end because of the weather. Right, we got a patient here, worried has got HAPE. We can't really safely go down. What can we do?
So the golden treatment is often oxygen, isn't it?
Yeah.
Do we have oxygen or not? Yes. And do we have enough? That's the other question.
Mm.
Because often you do have oxygen, but you may have one cylinder or two cylinders, and depending on the size of the group, you're thinking, actually, how long is that going to last? And what if somebody else falls ill? So there's all these dilemmas that start to go around to say, okay, so I need to give James some oxygen. I need to keep his oxygen sats above 90% if I can, and so that's important. Um, and then I've got to make that decision. How long do I leave him on the oxygen? Yes,
Yeah.
because obviously if I'm going to leave you on it overnight, yes, that oxygen is going to run out.
Pretty
Yes,
fast,
pretty
yeah.
fast, really, actually. So I've got to have some plan. This is where I'll be meeting with the group leader to say, okay, James is requiring oxygen at the moment. What I could do is reassess him every 3 hours to see, can we reduce the oxygen to see if he starts to recover, and reassess him, listen to his chest and see if things start to improve. I'd be very reluctant if I've diagnosed HAPE to bring you up. My plan would be to bring you down. That's the plan. How we do that would be a discussion between myself and the group leader to say, what are the logistics? What can we do?
Yeah. Okay. I mean, so the you mentioned, of course, before there about the people rushing down with sort of the wheelbarrows with the people wrapped up there. So we've got oxygen. What else we got at disposal
Yeah,
for
so we
HAPE?
have these gamma bags. Have you heard of a gamma bag?
No.
It's these hyperbaric chambers thing, yes, where it's so most of these groups that travel to altitudes above 4,000 meters will carry a gamma bag.
Okay.
I think it's really good as a doctor to inquire with the group leaders or the organizers to say, do you have a gamma bag? So the way to look at the sequence of events is this: descend, descend is the golden treatment, followed by oxygen. If you find that you can't descend, you've got a limited supply of oxygen, then that's when the gamma bag comes out. Okay, and if you've ever seen a gamma bag, it's like a huge, massive sausage. Yes, there's a zip at one end, and you unzip it. There's a little transparent bit where you can see through, so the participant or the patient can see you. And so essentially, what you've got to do is you've got to pressurize this bag. Okay, and the way you pressurize it is by getting one of the porters to pump air into the chamber. Okay, and then it's a sealed chamber, so you've got the patient in there. You've then you're monitoring them, so you've zipped them up. So the problem is, James, it's very claustrophobic in there. Okay,
Sounds it.
sounds it. So so we use little tricks like make sure the headlamp is on the patient, make sure you shine a little light into it, make sure you're sitting with the patient, explaining what's going on, keeping the company so that they know that somebody's outside. And the important thing to remember about the gamma bag is that it is labor intensive because that porter will have to continuously pump if it's a manual. If you've got an automatic one, that's great, where it automatically pumps, yes? But it's really important to keep an eye on the pressure because if the gamma bag is working, it can mimic a pressure around 2,500 meters inside the bag.
Oh God.
Yes. And the longer you keep the person in, the better it is for them. But again, we're not treating HAPE. All we're doing is we're buying time for evacuation. That's really important to remember. It's not like they suddenly jump out the bag and say, I feel great, I'm going to go up. You're thinking, absolutely not. You get down.
Yeah.
Yes. So, and the problem is, if I put you in the bag, after about an hour or so, it's probably good practice to get you out, just to sort of stretch your legs if you need to go to the toilet. But my experience is that there's a real reluctance to get back into the bag.
Yeah, yes, that right. Yeah.
So you have to be mindful of that. So a couple of hours, 2 or 3 hours, all I'm doing is it's in the middle of the night, I'm buying time until the group leader can organise appropriate transport, appropriate evacuation procedures.
Because you certainly don't want to be descending a mountain at 2 o'clock in the morning. Just too dangerous. Yeah, it's HAPE or falling into a crevice, I suppose, isn't it? Yeah, exactly. Yeah, sure. Okay. I mean, that sounds really very interesting about the ways we can treat HAPE. We've also mentioned HACE. So can you just give us a little recap of what HACE is?
So a lot of people think that haste is on a spectrum of acute mountain sickness. So with acute mountain sickness, that's that classic symptoms that when we reach above 2,500, you might develop a bit of a headache, you might feel a bit dizzy, you might feel a bit nauseous or loss of appetite. Those are almost like mild acute mountain sickness.
Mm.
And I think there's some studies have shown that when you do an MRI scan of somebody who's experiencing AMS, there's a bit of inflammation of the
Mm.
brain. Okay. And so you can see at one end, if we rest, if we give simple pain relief, if we rehydrate and the symptoms subside, then that person can almost continue their journey.
Right.
Yes. But at the other end of the spectrum is if you suddenly find that the headache starts to get worse, they're becoming much more exhausted,
Mm.
they're becoming confused. We sort of describe this altered mental state, yes? And the other classic symptom is ataxia.
Right.
Yeah, you suddenly do the finger nose and
Yeah.
the test that we do with patients who have had excess alcohol. You suddenly find that their coordination is all over the place.
Mm.
Yeah, they're confused. They've had AMS before. Then you're thinking alarm bells are ringing now.
Mm.
Okay, this person is developing high altitude cerebral edema.
Sure.
This is like a medical emergency.
Yeah. So there's confusion, ataxia, and just feeling.
Altitude,
Yeah,
exhaustion,
absolutely. Yeah.
yes. So.
Yeah, sure.
And
And
sometimes
yeah.
neurological symptoms, if it's severe,
Mm.
yes, in terms of weakness or in
Yeah.
terms of even cranial nerves.
Okay. And what can we do about that? I mean, are we still talking gamma bags and oxygen here, or is it a different kind of approach?
So the golden treatment is still
Descent. Yeah.
descend, okay? Give them some oxygen, yes? And then if you've got some dexamethasone,
Hmm.
that's what you need to give, either intravenously or intramuscularly. And then usually we sort of say, in those sort of situations, 8 milligrams is
Yeah.
what you give them stat,
Yeah.
okay? And then you start them on 4 milligrams of dexamethasone every 6 hours. And remember, what we're doing now is this: we're saying this person needs to descend,
Buying time,
buying
isn't it?
time.
Yeah.
That's what we do.
Similar with the gamma bag and the oxygen. I think that what's really hammered home to me in our conversation before I went, and our conversation and now and the previous podcast is that taking it really seriously, descending when it's necessary, is the only thing that can really keep you safe throughout these experiences. And it's interesting with this medication, and we talked about the Diamox as sort of prevention and helping to climatize. Dexamethasone sounds like it'd be a helpful one to have in your bag. Anything else?
Nifedipine is very good
Okay.
because if you look at the physiology of HAPE, high altitude pulmonary edema, there's raised pulmonary hypertension, yes, and that makes the vessels leaky inside the lungs, and that's where you get the fluid. So sometimes the assumption is that we should use diuretics to treat
Mm,
this, but actually that makes the condition worse,
mm.
yes, because sometimes the patient's already dehydrated and it
Yeah,
doesn't make any, yeah, it
yeah,
doesn't make it so.
dehydration.
Nifedipine is probably the tablet to consider because it reduces pulmonary hypertension, yes,
Mm,
which seems to be the underlying physiological cause of high altitude pulmonary edema. And the recommended doses, it varies. Some guidelines recommend a test dose of 10
mm,
milligrams and then 20 milligrams slow release every 6 hours. Others say that you can start with 30 milligrams modified release um, uh, twice a day. But if you suddenly find that they can't tolerate that, there are some other medications to have in your kit. And there's evidence to say that it reduces pulmonary hypertension.
right.
Yeah, so that's the logic there. So sildenafil, 50 milligrams, one tablet up to 4 times a day is something to consider if you find that they can't, for whatever reason, tolerate nifedipine. Yes.
Mm,
So I would definitely have those two in my kit.
yeah.
Yes. But like I said, we're aiming. These are almost buying time, really. Actually, isn't
Yeah.
it? They're not curative. They're just giving you a bit of extra time to bring the person down.
Brilliant. I suppose, sort of finally, just moving on to the last bit of this. In your experience, so when you're in one of these medical emergencies, and I'm guessing that there's been some times during your time in Tibet where you've been in this situation, how do you feel as the clinician? What sort of things are going through your head?
I think your adrenaline's
Mm,
on 24/7 because that's the important thing to remember, isn't it? You're on call 24/7
mm,
until the trip ends. Okay,
mm,
and I feel there's a sense of relief when you say goodbye to them all at the
mm.
end of a trip, and that's when you sleep well.
Yeah.
Before that, you're basically on, yes,
Mm,
and it's really important to make sure that you look after yourself. Yes, that some, what we often do is to get somebody that can almost be like a helper that supports you, yeah, rather than you working independently. And that helper will look after you. You say to them, look, if there's food, yes, can you make
I
sure
need
it's
some.
can you put it aside, yes, and all this sort of stuff. A cup of tea now and then was like, just some basic things, just to make sure that you're looked after and stuff. Because if you fall ill, like I said, the whole point is the doctor shouldn't fall ill. Otherwise, we're going to have some, difficult trip, basically. Yes. But yeah, the situations have arisen. Most of them, James, arise in the middle of the night. That's the thing to be warned about.
That's why your sleep is not so great, I'm sure. And then you've got to walk in the day.
Exactly, exactly. But I would say what you could do to mitigate the risk is to make sure you instigate regular screening opportunities. Okay, so what you would want to do is to explain to the group that you'd have a morning session, a drop-in session, first thing in the morning, yes, and that would be a combination of anybody that's fallen ill overnight, and that would also be an opportunity for you to eyeball all the participants. At least get their oxygen sats, get some obs done, yeah, get somebody to measure their temperature, their oxygen sats, just to make sure that they're okay. Do the Lake Louise questionnaire on them if you have time.
Wonderful. I mean, and I think looking after yourself is again is another recurring theme here. Really important to make sure that you're well looked after, well rested as best you can, and to make sure you're getting something to eat. And how do you make sure that you've got something to eat on your trip and you
Yeah, so like I said, be nice to your helper,
yeah.
yeah, because they'll look after you, and also make sure you pack enough emergency rations as well. M&Ms, you can't go wrong, especially the peanut flavored ones. Yes, those are like my emergency rations. When the trip is over, I sort of like have a cup of tea, get my M&Ms out, and think, oh, what a good trip it's been.
Absolutely, and thank you so much, Rashbal. And it's been a great trip through altitude medicine and preparation for that. I've learned so much, and I'm so glad I spoke to you before I went away for this, and stumbled upon all this knowledge that you have of altitude medicine. It's just been really fascinating. So thank you so much.
My pleasure, James. Look forward. Hopefully, it hasn't put you off for your next trip.
No, it hasn't. I still need to do Everest Base Camp, but I feel much better prepared now. I'm going to really respect the mountain, take altitude seriously, go prepared, and take and keep some M&Ms for the very end with a cup of tea.
Excellent.
Thank you so much. And hopefully everybody's enjoyed listening to this and have learned something. We'll see you again at our next GP Notebook podcast. If you've got anything you'd like to comment about this, please drop us an email, and we'll see you again very, very soon. Thank you.